Hello, and welcome to the Rest, Repair, Recover podcast. I'm Suzy Bolt. This is a space for anyone who's navigating chronic illness. We are here to share real stories, helpful insights, and honest conversations about what it really takes to help yourself heal a tiny bit every day. So whether you're in bed listening, you're on a gentle walk, or you're just needing some company as you go about your day, I'm so glad that you're here.
I am very, very happy to be sitting here today with an incredible doctor, Dr. James Kustow, who is a consultant psychiatrist and specialist in ADHD. Now, I know many of our community are dealing with chronic illness alongside ADHD or wondering about that, and we are going to be talking to James today about all of the things that help us understand this condition, chronic illness, and much more. So James, first of all, thank you so much for saying yes to this conversation.
Thank you, Suzy. Very nice to be here.
Great. Okay, so let's first of all help our audience begin to understand what is the actual link between ADHD, this dysregulated processing system up here, and chronic illness, because we're thinking that there are quite a few, right?
Sure. Well, actually, this whole area is pretty new in terms of research. For many years now, we've focused on ADHD's what we term comorbidity, the coexisting conditions that run alongside ADHD at higher rates than you'd expect. But
Such as
autism,
Okay.
such as depression,
Yeah.
anxiety disorders, substance use disorders, etc.
Yeah.
And really, comorbidity is like the norm rather than the exception. 70 to 80% of people with ADHD, by the way, I specialize in adult ADHD.
That's right, sorry.
But 70 to 80% of adults with ADHD have at least one other mental health diagnosis, at least one
Okay.
other. But what we haven't been looking at least we haven't been looking at it so clearly, and is the physical health comorbidity.
Right.
And that is something that I've been looking at for maybe 10 to 12 years now. And it's an interesting series of events that led me down this path. But the first of those was a recognition that many of my patients with ADHD, when I see someone and assess them for ADHD, I'll take a very detailed history. And more than most people, most psychiatrists, I will focus quite heavily on the physical health issues that they're presenting with.
Yeah.
And the reason that I do that was because I was trained as something called a liaison psychiatrist, where my specialism was that interface between physical and mental, between mind and body.
Yeah.
And so I was very used to looking at both angles on this.
It's the bigger picture, right?
Exactly.
What else is going on at the same time?
Exactly. And there's always a bigger picture.
Right.
So I would take quite detailed physical health histories for my possible ADHD patients during assessments. And over years, I started to notice there was a disproportionate number of people who had hypermobility, lax joints.
Yeah.
Often they didn't think much of it, and they just said, yeah, I'm a bit bendy, I can do odd things. Some of them, however, were really ill alongside the hypermobility. And they would have a diagnosis called EDS, or Ehlers-Danlos syndrome, that I'm quite confident your viewers, your group will really know quite a lot about. And I didn't know very much about this area at all, but I was finding really high percentages of people. I was like 35–40% of my caseload would have hypermobility, and I was like, this is strange. It's only about 10 to 15%.
There has to be a reason.
Yeah. And so my mind doesn't like these sort of questions hanging loose, and I just did a really big hyper-focused deep dive into it and uncovered some amazing things. So just some amazing connections, not just about ADHD. I actually started looking at hypermobility and EDS and everything that sort of clustered around it.
Right.
And then I shifted to look at, okay, how does this relate to ADHD and everything around it? And I came to realize that they're probably the same cluster,
Right.
which was fascinating, particularly because we're not used to looking from a distance, from a broader frame. We're not used to looking at the physical health problems with ADHD. So there might be little pockets of research around this time making connections with specific individual conditions. But it's a very different thing from seeing a network that's characteristic and common forming around this thing we've called ADHD.
Right.
So that was the start of the journey.
Amazing. And so obviously the piece around hypermobility, and obviously in extreme, we've got the Ehlers-Danlos syndrome, but what else is going on in the body that is driving this dysregulation? What other things?
Sure. Well, the question is, where does the dysregulation come from,
Right.
and what's the primary issue here?
Yeah.
And some people would argue that the primary issue is a problem with the brain and function, or in the brain, and whether it's brain chemistry with
Right.
neurotransmitters or brain hormones being off. But you can also equally go back to starting the journey saying that there's a problem with the connective tissue that might have knock-on effects.
Right.
You could equally go back to the sensory system and say that where there's sensory processing issues, that symptoms can build on top of that because of the way that we're engaging with the world. But what I've come to realize is that the reality is there, and then we attempt to codify it, to make sense of it,
Yeah.
to form clusters and labels and so on. And sometimes those labels are accurate, and sometimes the labels are too narrow and they don't take into account the bigger picture. I think, broadly speaking, looking at mental health and neurodevelopmental presentations, particularly in the Western world, I think our focus has been too narrow for a very long time. We always think of mental health as separate from
Right.
physical health.
Totally,
Completely.
totally separate.
And even the specialities couldn't be further apart.
Yeah.
You know, going through medical school and training to be a
Right.
doctor and seeing how all the different specialities interact. You know, often, you know, we're medical over here and you're psychiatry over there.
Right.
And we don't need to do your stuff and you don't need to do our stuff.
Right.
And it really couldn't be further from the truth.
Yes, and that's always amazed me about Western medical approaches, because we don't look at the body as one joined up thing. We look at it as sections, which is extraordinary because I feel quite joined up.
Absolutely.
I'm part of a whole system.
Well, I'm lucky because I came at this from a training in liaison psychiatry, which means
Right.
that I'm one of the few specialisms within medicine more generally that actually is trained to look at that bigger picture. But GPs are meant to do that, but they really have been so strained over recent years that I think that's been lost to a degree.
Yeah. You can't look at the bigger picture of someone's, entire life in 10 minutes when you're just kind of going, what is the most pressing symptom that we can deal with today?
Absolutely.
That's never going to give you the bigger picture.
And another thing I think we've strayed a bit in the Western medicine is we've become much more focused on symptom relief and just dealing with the problem in isolation and not really thinking about its roots and what needs to change in order to stop it reoccurring.
Right.
And
So preventative, and actually how do we stay well rather than how do we just dampen symptoms down?
exactly.
Yeah, I agree. Yeah. So let's come back to this link. So let's say I have a diagnosis of ADHD. I also have had chronic illnesses. I've had, glandular fever, which is Epstein-Barr virus. I've had long COVID. I've had all sorts of various other illnesses throughout my life, and essentially a very reactive immune system. How are those linked?
So if you asked me that question 10 to 15 years ago, I would say, no, they're just clustering together. isolated physical health problems, potentially some of the genes overlap between these physical health issues and ADHD. But actually, what I've come to see and understand over recent years is there is a quite characteristic network of problems linked very much to hypermobility, but has a very strong immune basis. In fact, it's got a multi-system basis, and individual parts of that network have been studied in isolation. Let me give you an example. So there's been a number of studies now showing that there are higher rates of allergies and autoimmunity in ADHD. A variety of different, not all allergies, but a variety of different allergies, and asthma. And atopy, so eczema as well. So we've seen that compared with the general population, people with ADHD have more immune dysfunction. And broadly speaking, we can say that the immune dysfunction is of an overreactive immune system. Dysregulated immune system. When you look at the hypermobility story, again, the connective tissue system is dysregulated, because the problem there is that collagen, which is the main structural protein of the body, is this protein that holds the system together, is lax, it moves more than it should, and it affects every single part of the body. Not just the ligaments and the tendons, but the gastrointestinal tract and the skin, the cardiovascular system. And let me just highlight that connection because it's really important. So collagen is present around blood vessels. And it's part of the ability of the blood vessels to react quickly to changes and to contract or to relax, so that we're able to direct blood to where it's needed in the body. Sometimes blood is needed in the muscles, particularly if you run away from something. Sometimes it's needed in the brain to think more clearly. Other times, when it's all quiet out there, it can go to the gut and deal with like the regeneration and the repair.
The rest, digest, repair,
And the system that manages that is called the autonomic nervous system. We understand the autonomic nervous system to be one of the main stress systems of the body. So the stress system of the body is also the system that shifts and directs blood around the body. If your blood vessels are essentially more lax, they don't contract as well, that is going to be less efficient. You're going to get blood pooling lower down, particularly when you're standing up. And a relative lack of blood going to the brain. And that lack of blood going to the brain is problematic because blood carries oxygen. Oxygen provides energy. And if you are chronically under-perfusing, under-supplying your brain with blood, because every time you stand up, you're relatively unperfused, then you will have symptoms. Now, in the moment, in an acute situation, you feel dizzy and lightheaded, and sometimes people will have a history of fainting more regularly. But that can also be happening at quite a low grade level over a long period of time.
It doesn't have to be so obvious, does it? Just be subtle, kind of like, oof, whitey.
Exactly.
That's often something I say, oh, I'm having a little whitey moment.
Exactly. And many people will just say, oh, it's just something that happens to me. And I happen to be hypermobile as well. Now, the other thing to say is that our immune systems are unbelievable. They're so unbelievable in what they can do. There's two components to the immune system. There's the innate immune system and the adaptive immune system. The innate immune system is what I suppose we've had for millions of years. It doesn't have a memory to it. So it doesn't produce antibodies and remember infections, which is a pretty amazing thing we can do. We have an infection, our system can remember it. Next time it comes along, it can knock it off.
Have this one, exactly.
So that's the adaptive immune system. That's more recent evolutionarily. The innate immune system's much older, and within its parameters, i.e. it doesn't have memory, but therefore it has to be super effective at dealing with threats. And the way it does that is there's a process of surveillance and recognition. A particular group of cells are responsible for this surveillance and recognition. They're called mast cells.
Right.
And the mast cells they're a form of white blood cell.
Yeah.
And they don't live in the bloodstream like many other blood cells. They actually cluster in the tissues of the body, and in particular, they cluster at the environmental interfaces.
Yes.
So where the body meets the rest of the world. And that is obviously the skin.
Yeah.
It's any openings.
Yes.
So
Yeah, yeah.
mouth and
Yeah.
gastrointestinal tract, genitourinary tract.
Right.
Respiratory
Yeah,
tract.
yeah, yeah.
You know, so all of those tissues inside where they are meeting with food or
Yes.
air, they have high concentrations of mast cells. Now, why are those mast cells there? They're there because more than most cells in the body, they've got hundreds of very sophisticated receptors on their surface for everything, for infections, different types of infections,
Yeah.
whether it's parasitic or fungal or bacterial or viral,
Yeah.
for allergens, for toxins of all different forms. They even have sensitivity to vibration, heat changes, or cold, anything where the environment's changing, which could signal that we need to react and respond. Now, normally, the mast cells are activated, their receptors are activated by something that suggests there's a problem. And then the mast cells decide, they're very intelligent, they decide what chemical they're going to release. And there's a whole host of different chemicals they either contain or they can form. So these mast cells are like little sacs,
Yeah.
and inside they've got these small vesicles with pre-formed chemicals. They're called mediators. And there are a number of pre-formed ones, but a whole host of others that can be created very quickly.
Wow.
And they are mainly inflammatory in nature.
Yes.
But they actually have two sets of functions. The first set of functions, the inflammatory. So if you have an infection, what do you need to do? Well, you need to draw in other cells that are going to actually manage it properly. You want to immobilize, if there's an injury or something, you want to immobilize it. So you might make it swollen.
Right.
And then you want to, you don't want it to move too much. You want it to repair, particularly if there's an injury, so it will become painful.
Yeah.
Where do all these things come from?
Yeah.
Well, they come from chemicals released into the
Amazing.
tissue, some of which stays locally, and some of which goes into the bloodstream, and it goes to the brain, and it's a complex interplay. But the point is that the mast cells are the beginning of a cascade of immune responses of the innate immune system
Yes.
that are there to isolate and deal with whatever threat is thrown away.
So let's look at threats for a minute, because obviously many of my community are in my program and part of the community because of COVID.
Sure.
So that came along as a pretty new threat to our bodies. We didn't have very much adaptive stuff to hand. So a whole load of new mast cell activity for many people was very apparent very early on. I remember the very first time I caught COVID, March 2020, the first thing I knew that was something that was going on with my body was I felt like I had food poisoning. So my gut went haywire, and then the skin stuff started. So just talk to us about that and how our bodies will have coped with that as a whole new threat.
Sure. So what COVID's done is it has taken this group of vulnerable individuals who have this interesting cluster of mast cells that are misbehaving, an autonomic nervous system that is dysregulated, and connective tissue which is a bit off. And through the immune responses to the infection and possibly also the vaccine, although it's a controversial area to discuss, and I'm very aware that we have to tread a bit carefully there, but it has in many ways unmasked this pattern more than I would ever imagine possible in a short space of time. So when people develop, there's the acute infection and then there's long COVID.
Yeah.
And in my understanding, on a very broad level, I'm not an immunologist and I'm not a COVID specialist, but my understanding is that long COVID is essentially a combination of two components. One is tissue damage from the virus that's left a mark, left scarring or problems, and an immune response that's become dysregulated that leads to fatigue symptoms, dysautonomia, so more dizziness, lightheadedness, brain fog, pain. Shortness of breath.
Yeah.
So what I'm pretty confident in that component, these are people with mast cells that have, for a variety of different reasons, become super sensitive and they've activated, released their chemicals inappropriately early and quickly and excessively. So we do want inflammation at the right level, at the right time.
To switch off at the right point.
Exactly.
Yes.
And then for the mast cells to move on to their next function, which is repairing the damage after the event.
Right.
And that's why some of the chemicals that they release are not to do with inflammation, but to do with tissue remodeling.
Okay.
Which might be another link with the hypermobility story.
Okay.
Because many people in your community will know that when their immune system's been activated, their hypermobility increases.
Right.
Their joint laxity changes.
Yes.
So we have this pattern forming whereby this triad or trifecta, as it's sometimes known, Ehlers-Danlos syndrome, hypermobile spectrum disorder on one pole, mast cell activation, or more broadly, if mast cell activation is a relatively new concept and it hasn't been studied nearly enough as it needs to be, but it's definitely a thing.
Yes.
And you might want to call it immune hyperreactivity.
Right.
Because I'm sure it's not just the mast cells.
No.
The mast cells are prominent and important, without a doubt. There's reasons we know that. But there's clearly other activity going on that's linked. So we might just broaden it. Immune hyperreactivity and then dysautonomia. And what we find is each of those things impacts the other.
Yes.
The mast cells release chemicals that widen the blood vessels to allow more inflammation and more swelling and more blood cells to reach the area, i.e. generate dysautonomia.
Right, and pain as well at that point.
They produce pain.
Yes.
The hypermobile body is perceived by the immune system as in danger.
Yes.
You move too far, the joint's tearing the tissue. The mast cells around that joint are going, oh my God, there's a problem, it's dangerous. We need to stabilize it. We need to release inflammation.
Do more.
Exactly. Yeah, well, it's basically saying there's danger here. And when the autonomic nervous system's not working properly and blood's not moving around, tissues get stressed, and that in itself is going to trigger the immune system. The whole network is interconnected. And what we see over time is two other groups form this party. They join this party. One is autoimmunity.
Yeah.
And that's not a million miles. It's not impossible to understand why. If your immune system is jumpy and responding excessively, it's not a number of miles away to go start making mistakes, start attacking the self. And there's some immunologists who believe that all autoimmunity is rooted in mast cell activation syndrome or disease. The other cluster that very commonly occurs in this group is gastrointestinal dysfunction.
Yes, very, very common.
Yeah, many of the people who you work with will have a long history of gut problems.
Yes.
What sort of gut problems do you see in your clients? What sort of stuff are they complaining of?
A lot of food intolerances, a lot of sensitivity, I know a lot of people experiment with low histamine diets, they experiment with low inflammation diets, very reactive to certain substances, very loose stool very frequently, or, the other way around, exactly.
Fast guts or sluggish guts?
Probably both, but probably a lot with fast. So, it's all moving through very quickly. A lot of people find that they can't eat comfortably because the pain is very uncomfortable, and swelling, bloating. So, yes, a lot of issues around how can I feed this body with a reactive gut? And it's a big conversation.
And, the words you use are really important there. Feed. Like, the gut is the route by which nutrition gets into the system,
right,
and toxicity moves out of the system. So let's just backtrack a little bit and just think about the gut for a second. So the gut, like the blood vessels, is wrapped in a layer of connective tissue, of collagen. And what does that collagen do in the gut? Well, first of all, it keeps it together.
Right.
And secondly, along with the smooth muscle movements, it's responsible for contracting and moving contents through the gut. Because any time that you have a tube that contains liquids, the liquids need to pass through the tube. Imagine in your home if you had a tube that got blocked, and what would happen? Well, the liquid that got stuck in that tube would go rancid. It wouldn't be good. Now, just imagine that in the human body, and thinking about how what should have come out and be expelled has been sitting there because the gut's not moving properly. Plus, the food you've eaten or the environment you've been in has triggered your mast cells, which are at high concentrations and are already jumpy.
Right, because you could be eating a really good diet. So many of my community are eating really healthily, but their body's saying, no.
Sure, and there's different reasons for that. What we find is this group is super sensitive to lots of things. Histamine is a big one, and it's a clue really that the mast cells are misbehaving a bit. But as well as that problem with the movement through the gut, that peristaltic process being impaired, the mast cells that are lining the inside of the gut and releasing these chemicals are causing swelling.
Right. Which makes it really difficult to pass anything through.
Exactly.
Right.
So you've got this perfect storm of stagnation, swelling, and contents which are becoming increasingly imbalanced or dysbiosis. That means bad bacteria growing.
Right. You want it out.
You want it out. Well, listen, the gut is a bit like a beautiful pasture with a mixture of different organisms living together, and it can either be beautiful and lush, or it can go quite wrong. And when it goes wrong, there's more toxicity around, and that toxicity can impact the lining through which the gut absorbs stuff.
Right.
It can allow the junctions which are meant to protect can be worn down. Toxins that shouldn't get in. Food that should be broken down to its component parts isn't. It gets broken down to middle ground substances that are toxic, and they get absorbed into the bloodstream, travel around the body, and cause inflammation.
Right.
And so you're also dealing with gut problems where the tissues of the gut are lax, and therefore this high pressure, imagine the tube's been blocked off, pressure's building, bloating, and that pressure causes outpouchings of tissue, whether it's hemorrhoids or diverticular or junctions of the gut, like the junction between the esophagus and the stomach. It's a junction where things sit nicely together, or if there's swelling, or if there is loose connective tissue, it doesn't form nicely together. So you get contents coming back up, acid reflux.
Right, hugely common.
Hugely common. All of the gut problems that we see can be explained when you understand the
this connective
pathophysiology.
tissue piece. Or
So you're seeing this network. I see that's the core. You've got the autoimmunity stuff linking to it, sometimes early on, but often a bit later on when the system's been inflamed for a long
while.
time.
Yeah.
You've got the gut stuff, which tends to spiral the whole thing. And before you know it, you're in a state of perpetual fatigue,
Yes.
pain, dysautonomia,
Yeah.
brain fog, and a whole host of neuropsychiatric symptoms that we would just label up until now as anxiety or depression or and the whole ADHD autism piece as well. So you might be wondering why as a psychiatrist I'm talking to you about all of these somatic or physical health problems. Essentially what we're talking about is a cluster of syndromes, what I would term somatically based syndromes.
And somatic, just for clarity.
Physical health.
Physical, yes.
Now, so I would call dysautonomia a somatic syndrome.
Yeah.
Because it's like an umbrella term for a variety of different presentations, POTS and Raynaud's and a whole host of other things as well. Often characterized by this orthostatic intolerance, standing up causing symptoms.
Yeah.
The mast cell immune hyperreactivity is definitely a syndrome. It affects every system of the body in very characteristic ways. I mean, this is not random. This is quite specific. You could tell me any system of the body, and I would tell you the sort of 5 key mast cell symptoms that are present.
This is what you would see if there was...
If the mast cells were going crazy. And without doubt, Ehlers-Danlos syndrome is a syndrome. It's multi-system. So we've got the gastrointestinal stuff. Like, we've got these multiple syndromes clustering together. And the reason why I'm focusing on it is because it became very apparent to me for a variety of reasons, not just COVID, but some other stuff that happened in my personal life and my family's life, that led me to understand that this cluster is driving neuropsychiatric features or symptoms.
Yes.
And it's driving those symptoms not for the reasons that we classically understand mental health and neurodevelopmental symptoms to be driven by, which is not enough dopamine, or too much dopamine, too much little serotonin, or problems with the brain. Problems,
let's just fix the chemical level.
I mean, it's not just chemicals that we talk about. We talk about the default mode network. We talk about the tracks that are connecting the different parts of the brain. But we're talking about the brain. And what I'm saying is that this is a body stuff that's, for various reasons, driving these symptoms directly in the brain through 2 main mechanisms, which should become obvious now. One is inflammation. System-wide inflammation. And people think, incorrectly, that the blood-brain barrier, which is this meant to be pretty sort of strong divide between the blood system and the brain, think it's, impermeable. But it's not.
No.
And as you get more unwell, it becomes more permeable. And mast cells are central in that breaking down of the blood-brain barrier. So you have inflammation in the body that drives inflammation in the brain. And inflammation directly in the brain. And you have not enough blood supply and oxygen getting to the brain to feed it because of the dysautonomia. And simply by those 2 mechanisms alone, you can explain most of mental health and neurodevelopmental presentations.
Interesting.
But not all of it, of course.
No.
This is a group, but it's a big group. It's a big group, and the group has been utterly neglected by our medical system. Each condition within it, whether it's hypermobility, dysautonomia, mast cell activation, gastrointestinal IBS, SIBO, maybe autoimmunity not so much, fibromyalgia, chronic fatigue,
asthma, eczema.
I mean, it's really stigmatized. almost psychosomatic, blaming the patient. It's just stress, it's all fine. And it's not fine.
No.
Because it's highly pathological and it's life damaging for a lot of people. And it's about time our system started paying more attention, applying less stigma, and taking this very, very seriously, because the sorts of presentations we're seeing, certainly in the Western world and probably across the world,
It must be.
are changing.
Yeah.
We're seeing massive upsurge in allergies and autoimmunity
Yeah.
over 60, 70 years, not just recently. We're seeing new conditions that are puzzling the medical profession, like chronic fatigue syndrome and fibromyalgia. We're seeing a massive increase in mental health problems,
Yes.
which is just being put down to stress of modern living,
Yeah.
whereas I think it's a lot more than that. Rises in autism that you can't possibly put down to more recognition. It's going up.
Right.
The question with ADHD has not been answered, whether it's actually going up. The current consensus is it's not.
Okay.
It's just being recognised.
It's just being recognised. Well, also, if we take that point for a moment, finally, women, and I include myself there, are being assessed under a slightly different set of assessment criteria to perhaps males. Because when I was assessed at 49, it shocked me because I said, oh, but I'm quite good at sitting still. I don't understand. I did well at school. School interested me. And it wasn't until I learned what all of the criteria were that I realized, oh no, okay, so I tick a lot of the other boxes, but just that one piece of, are you the naughty kid that can't sit on a chair at school, which seemed to be all that the media ever talked about, that didn't actually have to be the only feature. So why don't we talk about that? Because I think, one of the things that happens in my community is a lot of people feel very dysregulated with the conditions that they're living with. And then on top of that, we've got the, 40 plus female group entering into perimenopause, which brings all of this dysregulation anyway. And people question, maybe I've got ADHD.
Sure.
So if someone, and I know, so we are going to mention your book.
Thank you.
Which is great, I have to say, if you're wondering about this whole topic. But I am going to ask you now to just briefly summarize, what sort of things would you be asking someone if they identified with, if they were looking for an ADHD diagnosis? Because it's not just about levels of anxiety and inability to sit still and losing things. There's more, isn't there?
Sure. You mentioned the word criteria before, and I think that's a good place to start.
Okay.
So whenever we diagnose a mental health or neurodevelopmental problem, we base it on a description, a list of criteria that are documented in one of two classification systems. It's either called ICD, and we're on ICD 11 at the moment. Every few years there's a new one. Or that's more European one, or DSM, which is more of the American-based one, but we use that in the UK a lot still as well.
Okay.
And we're on DSM-5 now. And every condition will have a list of criteria that you need to meet in order to get a diagnosis made. And just before, just to be entirely clear, every single mental health and neurodevelopmental condition is diagnosed in this way. Characteristic cluster of symptoms, a symptom count, the presence of impairment causing problems, checking that it's not caused by anything else, and maybe one or two other time criteria, be present for 6 months, a year, or whatever it is. So there's no quick test you do, blood test, or to diagnose these things.
No.
It's pattern recognition and a judgment around impairment. Now, when these criteria are formed, it's really important to understand this. The symptoms that are listed for this tick box exercise are there not because they best describe what the thing looks like, but because they've been shown in studies to be the best differentiators between, for example, ADHD and bipolar disorder, or ADHD and anxiety. What symptoms stand out to make it. So that's really important because people think that ADHD is the list of criteria.
Right.
Which is very narrow, looking at attention, It talks about attention deficit, whereas many people will know that people can be hyper-focused and not pull away. So how do you explain that?
Right. I've got loads of attention when I'm interested.
And it focuses on hyperactivity, which is mainly with children and more with boys than girls. And in adulthood, it often gets turned inwards and becomes this uncomfortable inner restlessness, or hyperactive brain, hyperactive thoughts, or impulsivity. And people think that ADHD is inattention, hyperactivity, and impulsivity. But these are just a scattering of the problems of ADHD. So what I did in the book, which was, it was quite confident, but I decided to create a new model of understanding of ADHD that I felt, from all of my experience and all of the research and all of this body-based stuff that we're seeing, really captured the essence, the lived experience, the real ADHD in adults. And it's called the 10 domains of dysregulation. And I conceptualize ADHD as an issue with, or a disorder of, and people can debate for hours over that distinction, of regulation. A dysregulation problem.
Agreed.
And I've identified 10 domains. It's an arbitrary thing. There could be 15 if I wanted there to be, but the 10 most common domains that get dysregulated. And the first 4 are ones that no one would argue with who knows about ADHD. Attention, activity, hyperactivity, but the opposite end as well. Impulse control. And the 4th one is emotion. It's not actually in the criteria for ADHD, but emotional dysregulation is the heart of ADHD. It is the biggest problem.
We feel everything.
We feel everything.
Too much. We feel other people's stuff.
And we're very sensitive to slights or rejection.
Rejection sensitivity,
So rejection sensitivity is a big issue, and it's not even been studied properly. But anyone with ADHD will tell you it's a real thing. But there's 6 more domains. And I don't know if we've got time to go through them in detail, but just to give you a couple of them.
Go for it.
Immune dysfunction and inflammatory status is one of them. Arousal and energy expenditure. So that's the autonomic nervous system, the way that we use energy, this boom and bust pattern. I mean, and I include in the immune section the connective tissue dysregulation, because it's driving the immune system. There's sleep dysregulation, circadian rhythm.
Really common.
Dysregulation. Dysregulation of time appraisal. There's there's more. And I go into a lot of detail of all these different sections. But what it does is it builds up this picture of ADHD, which is much broader, much more multi-system. And it explains all of the strange things that we can't explain about ADHD, like how can someone be so dysregulated, so inattentive and distracted, yet spend 6 hours gaming? It's dysregulated attention, and it's very dependent on interest. Which is a very important learning for ADHD. Because it tells us that when you find the thing that you're interested in and passionate about, and you set your life up around it,
you're on fire.
You're most likely to live reasonably successfully with ADHD. A strengths-based model.
Well, that's what kind of beautifully brings us into the same room, because you also have ADHD.
I do.
As an adult diagnosis. And both of us, we have jobs where we're holding it together and making it work. And we found the things.
At least on the outside.
At least on the outside. There are days when I'm having to mask a lot. And maybe we can talk about that in a moment. But I think it's really important to say, you know, if you have an ADHD diagnosis, it doesn't mean that you've had a failed life. You may have just had much more difficulty in kind of getting to the place that you are now. But, you know, I want to show our audience, you know, I own my home, I've had kids, I've got a job, I'm really interested in my work, I love it, but that piece was really important. I had to be really interested in my work. I've been totally unemployable by anyone else my entire life. I could only do what interested me, which has had its moments. And I'm sure, you know, once you found the area for you within the medical training that you were working in, that for you, that must have been really lovely to kind of engage and put all of your focus in. So I'm really curious, because obviously this isn't something I talk about very much at all. I'm curious about what are the biggest challenges you've experienced as someone with ADHD? So what have been the things that you've gone, this is my bête noire, this gets me?
So I realized that I had ADHD when I was 33. And a bit like you, I'd gone through life just thinking, first of all thinking, this is how everyone is.
Right.
Then realizing, no, it's not.
No, it's not.
Some people are, who happen to actually be my good friends. That's interesting as well.
Right.
People with ADHD naturally migrate together.
Yeah.
For lots of reasons.
Yeah.
The buzzy, the excitement, the forgiving nature.
Right.
Don't hold grudges.
Yeah.
You know, if you're messing up a lot, you don't want someone who's going to give you a hard time every time. And also you don't give other people a hard time.
No.
Because you realise that it's difficult for you. And
Shit always happens.
Exactly. So I grew up knowing that there were some differences, doing my utmost to cover up those differences. And doing a reasonably good job of it most of the time. But in certain areas, it would let me down. And I would say that medical school examinations, where I had two big examinations a day for a whole week, and I'd relied on cramming to get through every exam before that, because the working memory challenges in ADHD. I know I'm bright, but I find it hard to, well, I've learned, the thing is, the other thing I was going to say is that when you have ADHD through your lifetime, particularly if you're not diagnosed, you learn over your life what works and what doesn't work. And you end up having this toolbox of compensatory strategies, of which some are really cool and adaptive and healthy. Exercise, you know, structure and routine, and others that are less so, you know, blitzing it through the night on Pro Plus when I didn't know that I had ADHD. I was just taking high dose caffeine, and not understanding why I needed to pop Pro Plus like there was Smarties and stay up the whole night. And a variety of other ways of regulating emotions that perhaps getting by, and then realizing later on that I was different, and then trying to work out what it is. Is it an anxiety disorder? No. I get anxious, along with most people with ADHD. That's not in the criteria either, because it's not a good differentiator. Is it anxiety disorder? No. Is it depression? No. What is it? And I concluded, actually, that it was a trauma reaction to an accident my mother had when I was 7 years old, a car accident, a really bad one. And she's okay, she survived. But as a 7-year-old, when you don't know your mother's going to survive or not for many weeks, and no one tells you anything because they're trying to protect you, but that's not really the way to do it.
We're just going to pretend everything's fine.
And you're sensitive, so you pick up these things. So I did a lot of work on that trauma. In fact, that's a whole separate story on trauma processing down that line, and how trauma interacts with ADHD is a fascinating area.
Well, this is Gabor Mate's work, right?
And Gabor Mate's work is great. I've trained with Gabor Mate. I've read his books. He's got a lot to add, but I just don't think he's accurate. With his suggestion that ADHD is all trauma.
All trauma, yes.
Because the evidence doesn't show that.
And the bathing of cortisol in utero.
The evidence shows that it's much more than that. It's very genetic. The heritability or the genetic loading of ADHD is super high. And these comorbidities with physical health problems that we've been discussing today, that links with trauma, and the trauma story is important there.
Which comes first?
I've got so much to talk about now. So the mast cells also have receptors on their surface for the main stress hormone in the body, which is the corticotrophin releasing hormone, or CRH. And it also produces this CRH. In fact, it produces more CRH, more of this stress hormone, than the hypothalamus does, which is meant to be the main production of it. So stress drives mast cell activation and inflammation.
Yeah.
Which is why many of the people who in your community will have got ill either following an insult of some form. It's usually an infection, and there's certain infections that do it more than others. COVID, Epstein-Barr virus or glandular fever, Lyme disease.
Right, common.
Really common. Mycoplasma, there's a few others, but those are the biggies.
Yeah.
Or they had an injury where they damaged a part of their body, had a car accident, got whiplash, or a psychological trauma.
Right, and I've seen this. Yeah.
Or a hormonal shift of some form, which is the menopause story.
Or the perfect storm. All of it. Right.
Exactly. And they all do often come together.
Yeah.
And then suddenly, their mast cells, which for the whole of their life prior to that were a bit jumpy, a bit of this, a bit of allergy, a bit of hay fever, odd skin reactions,
maybe more colds than
asthma,
other people.
maybe more infections, urine infections, tonsillitis recurrent.
Tonsillitis, yes.
Grumbling along, no big deal, I can handle this. And then along comes this insult.
Yes.
And bang, everything changes.
Yeah, you're
and pretty much from one day to the next, everything changes. And it happened with me, so I really understand it, and I never understood that before. And what's happened is you've basically sent the mast cells, in my model, you've sent them, you just ramped them up. They are on guard. They are scanning the environment, and anything that moves, releasing chemicals. So the food, the air, the mold, everything triggers you. And they don't stand down.
No, they just almost turn up volume knob constantly, right? Constantly.
And that's why I call the mast cell compartment, or whatever you want to call it, the mast cell as a group, or the, and the associated cells and that are working with them, as the third stress system or threat response system of the body.
Yes.
We talk about the autonomic nervous system.
Yes, we do.
The sympathetic and the parasympathetic, this balancing act. We talk about the HPA axis, which is the hypothalamic, pituitary, adrenal.
That's right.
And that's just so people understand, the hypothalamus and the pituitary are in the brain.
Yeah.
The hypothalamus releases CRH, which is a stress hormone, goes to the pituitary, and that releases and it's cascade down to the adrenal gland, which sits above the kidneys and produces cortisol. It also produces adrenaline, but in this story, it's cortisol, which is a stress hormone. And high levels of cortisol, I know you know this stuff, of course, and high levels of cortisol are responsible for a sort of chronic inflammatory presentation. And so you've got the HPA axis, the autonomic nervous system, and then the immune component of it. And I really see it like that, because what are these cells there to do? They're there to guard and protect.
Protect. And if your body is constantly thinking it's not safe, which is a really common internal experience for people with ADHD, then that is just constantly on guard, much more so than someone else.
Absolutely.
And so was there a link for you with illness that led you to start to look at, do I need to go for a diagnosis? Is that what triggered it, or was it other stuff?
No, it wasn't that. It was the recognition. So first of all, I just had this moment where I read an article. So I managed to get through medical school, become a regular doctor for a few years, decide to specialize in psychiatry, become a liaison psychiatrist, looking at the body-mind stuff, and actually go quite far down this line without being able to work it out myself. It was unbelievable. I think it was unbelievable. And what happened was I just read an article on adult ADHD as it was becoming more understood that it continued into adulthood. And the article described me. It just described me. And I was like, wow, And it's the introduction to my book.
Great.
In fact, if people want to hear the story without buying the book, if you go to Audible, I read the book on Audible.
Oh, great.
And the introduction is one of the taster things. You can listen to it.
Yeah.
And it tells that story. And it was literally like a, wow, that's
Amazing.
it.
Amazing.
And obviously I had to go through the proper assessment process. But no, none of this stuff, this health stuff, I'd got anywhere near it at this stage.
Okay.
So what happened then was that I started getting interested in working in ADHD, and I trained and I learnt about it, and I became, had more expertise in it, and I saw lots and lots of patients, and I started seeing these physical health problems clustering, as I mentioned before. And then, as almost like the next chapter in the story, I was invited to do a lecture tour in the Middle East. Not on ADHD, because I hadn't even got into ADHD yet. But, well, I had, but I wasn't at that level. And I got a tick bite while I was in Kuwait.
Okay.
And then I didn't even know what Lyme disease was really. I mean, I knew it was this infection that ticks cause, but
it wasn't being talked about.
It wasn't really. But I worked it out quickly, because I went from having loads of energy to a few days later just feeling like the battery had run out, and my mood had gone low, and I'd never got low before. So I worked out that it was Lyme, and I had treatment for it, and I never properly, fully recovered from it. And it sort of primed, that was the insult for me.
Yeah, it was.
It primed my immune system, and I've had a string of things since then. And mold toxicity was one of them.
Okay.
I knew that the reason why I got ill with mold was because my immune system was a combination of my immune system was too jumpy and an exposure.
Yeah.
And I must tell you, mold is the most toxic, dangerous thing. And I never appreciated that before.
Right. It is talked a lot about in our community, but it's something until you've actually lived the experience or know someone directly who has, that you don't take seriously enough.
Wow.
But it is really, really brutal to the body.
It made me so ill.
Yeah.
And I'm still recovering from it.
Amazing.
And when I got ill from the Lyme with the mold layered on top of it, I started noticing that certain foods would trigger me. And what did that mean? My whole esophagus would swell, mast cells.
Wow.
And I wouldn't even be able to swallow a pill.
Wow.
It would just get stuck. I was regurgitating. And I was like, what is going on? I was convinced I had a cancer that was blocking my esophagus.
Yeah.
And investigations. And by the time you go for investigations, like you go on a list and 3 weeks later, the mast cells are quietened down a bit. You don't know why it's happening in the first place. And I started to notice that it was fermented foods or high histamine foods.
High histamine foods.
And I started mapping this thing out. And then one other thing happened in the journey, which was like the mast cell piece of the puzzle really coming together. And that was my youngest daughter, Sophie, who is 12 now, and she's given me permission to talk about her and her story.
Thank you, Sophie.
She's lovely and she's well now, not fully recovered, but well. But when COVID kicked off, and I don't know if it was COVID or the stress of COVID, but she developed overnight a very dramatic presentation of what looked to the naked eye like severe OCD and separation anxiety and rage attacks and neurological twitches and all sorts of strange things. Her personality changed one day to the next.
Amazing.
And her dad, seeing this unbelievably severe presentation, is a psychiatrist saying, this is not how OCD presents.
No.
It presents gradually, usually.
It doesn't just start.
And it doesn't come with neurological. So I was like, deep dive time.
Quick.
My daughter is in a terrible state, and I just got to work out what it is.
Yeah.
And I did. In a week or so,
my God.
It was PANDAS. It was pediatric autoimmune neuropsychiatric disorder associated with streptococcus infection.
Oh my God,
this is
the strep piece.
autoimmune
Stop.
brain condition, which when you get a strep sore throat or other strep infection, your immune system makes a mistake, and rather than attacking the infection, it attacks the basal ganglia of the brain, and it's exceptionally severe. And I've never seen children so unwell as they are with PANDAS. Now, that was like, I remember it. I was sitting there, my daughter was really unwell. I was getting this thing going on with my swallowing throat, and I was thinking, what is going on?
What is going on
and
here?
One night, I was up 4 a.m. researching. I worked out it was PANDAS, and then I realized PANDAS is highly likely to be linked to mast cells.
Right.
So I went to the doctor, the professor of immunology, Gareth Morgan, who's the top guy in the country on PANDAS.
Great.
And I said to him, I've worked it out. It's a mast cell disorder. And he I can say it now because we've talked about it before. He basically said to me, yeah, sure it is. I'm sure it is.
Whatever.
And then we got Sophie well. I insisted we add in antihistamines to her management. We got her well over months. This wasn't a quick fix. She's still on antibiotics, anti-inflammatories, antihistamines, and a load of supplements.
Wow.
But we got her well.
Yeah.
But a couple of things happened. Well, first of all, the story with Professor Morgan was interesting. 3 years later, a few months ago, we went back to see him, and he said, James, I'm really sorry, I have to apologise. I didn't take you seriously, but I went away and I read a couple of things that made me think about what you said, and I did my own deep dive, and you're right. And then I shared it with my PANDAS colleagues around the world, and now mast cell activation is a centerpiece of PANDAS. And it was like very validating, because I remember the moment I worked it out.
Yes.
And I think that knowing about mast cell activation and how it drives many other presentations, whether it's autoimmune or I think fibromyalgia, chronic fatigue.
Does Sophie have any hypermobility, neurodiversity?
So Sophie had ADHD diagnosed already.
Okay.
She didn't have OCD.
No.
She's not obviously hypermobile, but can do a few things.
Some things.
My
It doesn't need to be
other
everything.
daughter is exceptionally hypermobile.
Okay.
She can do all sorts of strange
Stuff you
things.
shouldn't be able to do.
I'm hypermobile,
Right.
but not in your classic way.
Yeah.
Down the spine, and it's axial hypermobility. So, and do you know what happens when your neck and your spine are hypermobile? Everything tightens up.
Yes.
And so that saying, oh, I can't be hypermobile, I'm quite the opposite. My body's just rigid and tight. It's a clue.
It's a clue.
And it's often a clue that it's down the center. And, you know, I was having issues with jaw, temporomandibular, neck problems.
Yeah.
Didn't help playing rugby like a true ADHD and getting knocked out and having lower back, hips, legs externally rotated. I've had knee problems, ankles always going, flat feet.
Right.
No, it's that sort of pattern.
Yeah.
The reason that Sophie's story is important and how it links back to this is that when the inflammation goes up, her PANDAS flares up.
Oh, bless her.
OCD goes really bad.
Yeah.
Inflammation comes down, i.e. we treat it and we bring it down, the OCD comes down, the ADHD comes down.
Amazing.
I was seeing I've seen over a 3-year period a direct correlation between inflammation from another reason and mental health and neurodevelopmental symptoms. And when I saw that, I realized this is common.
Yes. Yes.
It might not all be PANDAS, but this is common. How many people's mental health and neurodevelopmental problems are being driven by an inflammatory process? That's a big question.
Right.
Because it changes the way we treat it.
Well, also, it brings us back into that question that our community constantly has. If I don't have a dysregulated gut, or if I don't have, you know, a skin something going on, should I be thinking about regulating my mast cells? The answer is yes, because so much of what is going on for people with something like long COVID is actually mast cell linked. And just because it might not be doing the typical thing that you're seeing doesn't mean that it's not going to be showing up in all sorts of other ways. And that piece that you just shared with Sophie's story there is really fascinating, because so many people have got sudden onset of extreme anxiety as a result of this illness.
Yeah.
And then they go to their GP and their GP says, well, the whole thing's probably just anxiety. Let's get you in an SSRI. And actually what they're not doing is treating why the anxiety has come there in the first place. They're just dampening it for a bit. So coming from this mast cell management approach sounds incredibly important.
Very important. And when you know that this is the case, you suddenly, everything else looks a bit different. So for example, SSRIs as a group are anti-inflammatory.
They are.
And fluvoxamine, which is one of the is particularly anti-inflammatory.
Right.
That's what my daughter's on in terms of the medication for OCD, because the studies show it's most anti-inflammatory SSRI.
Yeah.
And you learn that many of the drugs that we use in psychiatry have powerful antihistamine effects.
Yes.
Lots of the drugs, including things like quetiapine and the tricyclic antidepressants, particularly anything that has sedation or sleepiness, has quite a strong antihistamine effect. Other things that you start to recognize. So it's not been studied extensively, and it needs to be, but there's signals that people with ADHD have higher rates of dysautonomia, POTS and so on.
Yeah.
There's clues to that, but there needs to be more research. When you know that, and I think it's going to be a very strong comorbidity, by the way. When you know that, you suddenly think, okay, stimulant medication pushes up the blood pressure, and stimulant medication, in America at least, is used to treat POTS.
Right.
So are we getting some of the benefit from ADHD medications in particular subsets of people with ADHD as a result of the side effect of the medication? And I think the answer to that is most certainly yes.
Well, I know I took for 18 months citalopram. My blood pressure was more regulated and I didn't get as many infections or, viruses. I was healthier than
that's
I'd
an
been.
antidepressant. I was talking about stimulant medication for ADHD.
Oh, right. Sorry, yes.
However,
I was thinking about the inflammatory piece.
However, the inflammatory piece is relevant, as is the reduction in stress.
Yes.
Because
my system
we can't
felt
separate the stress and the immune system.
Yeah.
They are linked.
Yeah.
And we can't separate the stress and the gut either.
No.
Because the vagus nerve, really important link with the immune system.
Yeah, absolutely. And I mentioned it because I can remember when I deliberately chose to come off them, it felt like I was coming back out into the familiar choppy waters of being in a body that was something that needed to be regulated a lot with movement, yoga, my exercise when I'm well enough to do it, and all of those things, which leads us to another problem with our chronic illness gang. They can't exercise in the way. But I think, moving and doing all of the work that we do in our program, and I know, we're going to talk about your solo soma stuff now, is actually really important. So just because you can't exercise doesn't mean you shouldn't think of moving and working with your body, because if you have ADHD and or a dysregulated nervous system for whatever reason, you can help yourself signal safety to your mast cells actually by doing stuff that isn't going to exhaust you.
Sure. You do a lot of stuff through exercise.
Yeah.
You release endorphins, you release dopamine, and you clear lymphatic drainage, you move blood around the system. And
it doesn't have to be vigorous. So if we just think about my cohort, it doesn't have to be vigorous. We do some really lovely recumbent movements, and people always just feel the sense of
But normally, I imagine quite a large proportion of your community will have used exercise historically to regulate.
Absolutely.
And then
runners,
injury hits,
boxers, swimmers, the whole
injury hits, something hits which makes you unable to exercise. And that's like, wow, my primary coping mechanism.
The coping mechanism.
Which boosts up dopamine and compensates for a fundamentally under stimulated dopamine system.
Right.
Dopamine, by the way, is released in two different main ways. This is a model, a theory. There's the tonic release, which the analogy is like a swimming pool, that dopamine is filling the swimming pool and the pool is remaining, say, 3/4 full the whole time. Yeah, there's some coming in and there's some coming out, but you've got this pool.
Yeah.
It never goes right down, it stays there. In ADHD, the pool is reduced in its height. There's a less of a tonic pool.
To start with.
The other release system of dopamine is called phasic release. Pulses, bursts, usually in response to sex, spicy food, drugs, alcohol, exercise, anything that stimulates you.
Yeah.
And if you're living with a low tonic pool of dopamine, which ADHDers are, and
this is my biggest challenge.
Yeah. So when you realize that you can feel, and you know, when you've got that low dopamine state, you feel under-rewarded, there's a sense of something's not right.
I'm dying.
I'm not comfortable.
Yeah.
I need something.
Yeah.
And then you find something, you find exercise, I found it. I'm
Yeah.
doing it. But then you can't do that anymore. So that's why people suddenly go, oh, that cigarette made me feel okay for a few seconds, or, you know, oh, the alcohol is doing something, I'll have some more of that.
Yeah.
And that's the link with addiction.
Yes. And
so what we do in ADHD when we treat it with medication, and medication is really effective in ADHD. It gets a bad press, but I've got to tell you, it's amongst the most effective group of medications out there. It lifts the tonic pool.
Great.
You're less reliant on needing that thrill, that excitement, that new project.
Yeah.
You asked me before, where did things go wrong? I used to take on new projects and new ideas, and someone told me something, and I'd go, oh, I love that. I'm going to go and do it. Juggling all of these things like,
Yes.
And that takes a toll.
Yes.
It takes a toll on everything, on your energy, on your sleep, on your stress, on your relationships. Everything. And the good thing is, if you're reasonably bright and persistent, then some of those balls will turn into something.
Right.
And that's what happened with me.
Yeah.
A few things manifested, but a lot of things didn't.
Yeah.
And that's okay. I think that's the story with most people who end up being, doing something and making something. They'll tell you their story is of hundreds of things that didn't go anywhere, and then one or two things did, and then it sort of builds from there. But it's exhausting doing that.
Yes.
And it's exhausting not having an obvious solution to your low dopaminergic state.
Absolutely. Yeah. For me personally, the low dopamine state is something that I find has ended relationships, has ended friendships, has ended, interactions professionally. I literally feel like my brain either needs to be plugged into the electric grid, the national grid, or I'm dying, and that's really difficult if you're in my life, because I'm either high and engaged and present, or I am sitting in a dark room just going, I feel like I'm dying. I gave it code the other day for eating at the Death Star canteen.
This could be partly dopamine and partly dysautonomia.
Right.
Yeah.
Yeah.
And I know that you've said you struggle with that stuff.
Yeah.
And it's a real big deal. And it's so many symptoms are generated by the autonomic nervous system not working quite right. Brain fog, word finding difficulties, sleep issues.
I'm so fascinated by how it's all linked, because when we learn about these things, we learn about them in these little separate pockets of information, and then this incredible moment happens where it's all brought together, which is fantastic. I'm so happy I'm talking to you about this.
I realised one thing before we move on to something. You asked me a question earlier about women in their perimenopausal period, and I think it's important to go there just for a moment. So women have been chronically neglected in terms of ADHD and autism, so neurodevelopmental problems, or more broadly, partly because boys attracted attention more.
Yeah.
They were the hyperactive, boisterous, running around, noisy, getting into fights. Whereas, and it's a bit of a stereotype, but there's a degree of truth and there's evidence to support this. Girls were often more dreamy, stare out the window, not causing a problem, get missed, playing with their curls, and and were missed. And we sort of saw ADHD as more of a boy-y thing.
Yeah.
I think women more generally have been neglected, and that's changing now, I'm pleased to say. But something interesting happens in the 40s, usually, I mean, different, is that as the estrogen level in the system starts becoming more dysregulated in the perimenopausal period, it's not so obvious that it just goes down, it just gets dysregulated. Guess who registers that? The mast cells.
Right.
Mast cells have got receptors on their surface for estrogen.
Yes.
So when estrogen gets dysregulated, the mast cells get dysregulated and there's more inflammation. And it's not complicated to see the links between perimenopausal and premenstrual symptoms and mast cell symptoms.
Yeah.
They're very overlapping.
Yes.
Now, the other thing that happens when estrogen starts going down or dysregulated is dopamine does in parallel.
Okay.
So dopamine levels reduce in line with estrogen in women in their 40s.
Yeah.
Women with ADHD, interestingly, have been shown to have earlier menopause. Those that have a diagnosis of ADHD, it gets worse.
Yes.
And those who never got a diagnosis, either because they were just sub-threshold or they were missed, which is very likely. We're in catch-up phase now, by the way, which is the main reason why numbers are going up.
Yes.
Because there's a lot of people, especially women,
just like
who were missed.
Yeah.
And now they're saying, no longer am I going to be missed.
Yeah.
This is what I've got. The problem comes. So this is like unmasking of ADHD. The problem is there's a group that didn't have ADHD symptoms in childhood that are having it for the first time. I mean, maybe it's the demand. So how do we deal with that as a speciality? Because ADHD by definition is a neurodevelopmental problem.
Right. So it should have been there from the start.
Yes.
Yes.
And there have been some studies that have come out in the last 10 years, a bit longer, that have seemed to indicate that there's an adult onset form of ADHD.
Interesting.
Which doesn't fit the model.
In men and women?
I mean, I'd have to go back to the studies to look at, I didn't actually, it was a while ago now, but the studies have been explained away by, there was a scattering of ADHD symptoms, it just wasn't captured. But when we go back and we look in more detail, we can find some clues. Or there was a lot of scaffolding, that the family provided all this support, the school provided support, and it wasn't picked up. So there's lots of explanations of why it might be wrong. But there are also question marks in my mind as to maybe it's right. And maybe it's representing... Right. Maybe it's representing a changing picture, and that some of this group that we call ADHD is this group that I've been talking about, who are getting progressively more inflamed, and their brains are getting progressively less blood and oxygen, and they're getting brain fog or chronic orthostatic intolerance, and they are experiencing symptoms that are a little bit difficult to separate from ADHD. I don't know. I'm hypothesizing. But
let's talk in 10 years.
Let's talk in 10 years. And if I'm right, then especially about the links with the mast cells and the perimenopausal symptoms.
Yes, and this decline in estrogen and the decline in dopamine. And the mast cells
being centrally important in that.
Right.
That is not something that's commonly talked about. And I think it's important.
Yeah. Oh, watch this space. I'm sure there's a lot of women who'll be watching this going, yes, that feels like that's happening for me. The lived experience. I'm sure you could capture 1,000 stories. And
last thing to say before I answer, I'm sorry, I want to make sure, treating mast cell symptoms without understanding the cause can be dangerous.
Okay.
Because think about it, there's lots of things that can drive mast cells.
Yeah.
You might have another illness that's in the background that you've missed, and you might there might be mold in your home, and if you go ahead and just suppress symptoms, which is what you're doing when you take regular antihistamines, believe me, it's better to reduce inflammation than to have it.
Yes.
So even if you are looking for the cause, you would still try and calm the system
Start
down.
work.
Yeah, but
Yes.
it doesn't end there.
No.
It begins there. You've then got to puzzle out what is driving this.
Right. Where
Is
is this
it my
coming
connective tissue issue?
Right.
Is it mold? Is it this Lyme disease that was never treated properly?
Right. Yeah. Right.
Is it an allergy that I didn't know about? To dog dander, and I've had a dog for 20 years. What I'm trying to say is that you've got to try and work out the source, because
Don't just dampen the symptoms.
Don't just
Work
dampen
out
the symptoms.
why this
Okay.
is going on. Yeah.
so
great.
that's the caveat
Yes.
to everyone going off and taking loads of antihistamines
Yes.
and going, I feel better.
Yeah, great.
Because amongst
Tick.
them there will be some people who are covering up an underlying problem,
Something
and
else.
that is important.
Yeah.
And that's why it needs to really be guided by someone who knows what they're doing.
Yeah. Great.
But that's the problem.
Yeah.
Not many people do.
So that's very good advice, because there's a lot of people out there taking their antihistamines as a result of, you know, maybe their response to the COVID infection. And then as things begin to settle, they come off the antihistamines, and then there's still some responses going on, and they're going, but why hasn't that dealt with it? So there may be other things they need to be checking for in their environment and in their history to make sure that they're ruling all of those things out. So this is great. So this kind of brings us nicely back around to the work that I do, and I know the work that you also do, around how to bring safety signals to the body by yourself. The work that that we can do to basically calm some of this inflammation in our mast cells without needing to take a drug at all. There is a lot that we can do to help and support our bodies to just feel a little bit safer, isn't there? So
Absolutely.
I know in our program, we do all sorts of things, from obviously breath work and gentle somatic movement and gentle yoga and qigong and tapping and all of those things. And I know you're a super fan of tapping, because you popped out and did some just before we did this interview. So why don't you talk to me about the benefits of those sorts of things in general, so that people can understand the why of us doing this. And then I know that you've got something yourself called Solo Soma, that you've kind of put it all together. So talk a little bit about this.
A few months ago, I released and launched Solo Soma, which is it's quite unique actually, and it's not dissimilar to what you're describing, but it's packaged into one. So it is a 20-minute movement meditation. So it follows a set sequence which incorporates what I've judged to be the most potent elements of about 14 different existing approaches, some old and some new, ranging from yoga, Pilates, Qigong, eye movement, EMDR, eye movements, EFT, tapping.
Yeah.
A lot of focus on the vagus nerve and stimulating the vagus nerve, particularly around the ear region.
Yeah.
Breath work, lymphatic drainage support, touch, self-touch,
Right.
the havening technique.
Yeah, I'm a big fan.
Point stimulation, physiological interventions like inversion and the Valsalva maneuver. That's a good vagus nerve thing, and you need to be careful with it. But what I did was I just pulled together these components and weaved it into a flowing 20-minute practice that I actually invented for myself.
Lovely.
Over years.
Yeah.
I would add a bit here and add a bit there. I didn't even manualize it to start with. I would just say, I do this bit next and I do that.
Feels nice.
I did some of it in the shower, because making use of the water, the hypnotic effect of the water, but the cold water as well. Also, it was experimental. It was intuitive. And then I realized that it was really helping me. So I manualized it, and I started sharing it with colleagues, and they were like, wow, this is good. And then I started sharing it with patients, and I improved it, and then I decided it's too much to go through it with everyone, so I'm going to turn it into a proper manual and a set of videos.
great.
And I did that, and I released it in October, November, and it's out there for people to download. It consists of there's an introductory video, but there's two main videos. one with a voiceover that takes you through every part of it and how to do it. It's formed into this very easy to follow structure.
Yeah.
It's got a tune-in phase at the beginning.
Nice.
6 separate exercises, about 20, 30 seconds each. And then it's got 3 parts, and each part have got 3 component parts. One is touch and flowing movements. Another one is points and eyes, point stimulation and eyes. And the third is the vagus nerve, lymphatics, and tapping down midline. And then there's a shield up at the end. And so the first video takes you through in detail all the different components and why you're doing it, how you're doing it. The second one is still a video with music, but no voiceover.
So you can just
follow.
Nice.
And the third option is just audio. And I got my close friend, who's a very experienced and well-respected composer worldwide, to do the music for it.
Nice.
And there's a manual with beautiful pictures. And I launched it. I didn't know what the world would make of it, but it's been really, really well received.
Great.
And the best way of describing it is an autonomic nervous system rebalancing protocol. And I know there's many different approaches for this. There's DNRS and there's various other big programs. They're often very expensive.
Yeah.
And you have to do all these different things and it, lasts. This is 20 minutes. The same thing, you can vary it a bit. It's not expensive. And I think it gets unbelievably good results, particularly in the chronic illness, hypermobility, neurodiverse communities, anxiety management. And I know it works. The question is which components are the most powerful bits of it.
Right.
And I look forward to someone, hopefully, maybe one of your listeners is a keen budding researcher, wants to come and unpick this and try and work out what the most effective bits are.
Interesting.
And but it's changed my life. It's changed my life, just in terms of what it's brought to me on a day-to-day basis. I wake up, I'm aching, I'm, whatever. And then by the end of this 20, 25 minutes, I'm energized, I've cleared the cobwebs, I've moved blood around my body, I've stimulated my vagus nerve, I've got my lymphatics moving. And I also bring cognitive things like the power of intention, gratitude, and to a degree awe as well.
Yes, the research on awe is beautiful.
So I've brought the cognitive components into it. And repetitive, rhythmical, bilateral stimulation.
Yes.
Most healing, I've noticed this as well, and I'm really interested in frequency-based medicine. So things that use a frequency, whether it's tapping, eye movements, pacing, shaking. And there's many devices that use frequency.
Yes.
And for some reason, most healing modalities employ frequency of different forms. And there's a lot of that going on here as well.
Oh, gorgeous.
I think it's the most exciting thing that I've created to date. I love it. And even more, I mean, the book was such a big thing, but this was going on 5 years before the book.
Yes, okay.
And so it's, it's a big project for me.
I love that you've taken everything that we kind of offer and you put it into this perfectly formed little kind of like diamond of work. I love that.
I'm going to give your community a big discount code on it, 60% off it.
Yeah, we can check it out.
Yeah, if they're interested, I'll give a code that you can use and then they can check it out for like a fraction of the price.
All We'll make sure that's dropped into the comments and stuff, obviously. And then let's just finish by talking about your fantastic book. I did read it all, from front to back.
It's encouraging.
Which is rare for someone with ADHD to concentrate on something for so long. The thing that I love about this book is it talks about the different things that you can do to help yourself, which don't rely on drugs, because a lot of people might not necessarily need to even go and get a diagnosis. If they're beginning to go, I think I've got this, this and this going on, but there's loads of things you can do to help. And actually that might be enough. A lot of people say to me, what did the diagnosis give you? And I say, kind of reassurance that it was a thing. But did it change
wasn't your
anything?
fault.
Right. That I was part of this kind of subset of people that just had this brain that did this. And actually there's loads of brilliant stuff about my brain, which I love. And there's some stuff that's a bit tricky sometimes. But did it give me anything else? No, not really. And I was lucky that I discovered the importance of yoga and kind of looking after myself. And I surrounded myself with people who were kind of interested in mind-body work for my entire life. And so all of that has, I think, helped me. And when I read this, I think, gosh, there's just loads of stuff here that people can do and practically just help themselves with without even putting themselves on a list. And if they want to put themselves on a list and wait for a diagnosis or go in pursuit of one, then it talks you through the stages of the diagnosis. So you can kind of go through that process a bit by yourself and work out, is this going to be worth it? Am I ticking lots and lots of these boxes here? And then you've got a brilliant section on the meds. But that's not the first bit, that's the last bit.
Yeah, it is purposely the last bit.
I think it's really important to notice that. And then you talk about what they do and how people take them and the different combination of things, which I know I'm going to go back and have a look at again, because I was just trialed on 3 Ritalin a day, which blew my mind. So I stopped instantly because as someone with ADHD, I have a more sensitive system.
As someone with ADHD and chronic illness, that's the key bit. Not everyone with ADHD is more sensitive.
Right.
But this group is.
Right,
and
yes.
they're really sensitive. And many, many people at the starting dose are lost.
Oh my God.
So you have to go in extremely low.
Yes.
I'm one of those people.
Okay.
I'm on Ritalin.
Right.
And if I had taken at the beginning 10 milligrams 3 times a day, I would be knocked flat. But I'm now 5 milligrams 3 times a day.
Okay.
But it's taken a while to find that balance. But listen, this book doesn't focus solely on meds.
No.
And it doesn't focus
Brilliant.
solely on the other stuff. But I don't discredit meds. I take them. I think meds are really important.
Well, I was just about to say, I am curious now to go back. Obviously,
Sure.
I had one bad experience and went, I'm writing that off. That's not for me. And I wasn't supported by the clinic that worked with me in any way, shape or form. They just said, please, can you take them for 3 months at that level? And I just said, no, that would be
That's the problem.
ridiculous. So I stopped. But having spent time talking to you and listening to your story about it, I'm definitely going to go back and reread and see if there's another place for me to open up that conversation. Because, sometimes I think I need a little bit of help with this. And, I do all of the body work. I've got all the coaching skills. And sometimes I just need a little bit of help. So it's been a really great book for me to read as well. How to Thrive with Adult ADHD.
And actually, I introduced the 10 domains model in there, 10 domains of dysregulation, and solo soma.
Yes.
And I map out the somatic super syndrome that I talked about before. It's a model, it's a visual model, the somatic super syndrome and its neuropsychiatric signature.
Right. So that's basically a kind of map of all of the bits that we've been talking about and how they all interplay together and show up in this condition.
Focusing on the neuropsychiatric stuff particularly, because it's not new that this pattern exists.
No.
What's reasonably new, I think, and very important from my perspective, is that I think it's an enormous driver of mental health and neurodevelopmental problems.
Right.
And that's the bit that's not recognised.
No. So really coming to understanding all of the things that we've been talking about today is going to be crucial for some people, I think.
We've covered a lot of ground today.
We've covered a lot of ground.
Thank you.
I think we've also got a 10-year appointment to check back in again on the mast cell stuff,
that's
because that feels really important.
That's true. I'm quite confident in this one.
Yeah.
But, most new things that the medical profession hasn't learnt about at medical school get disregarded, stigmatised. The individuals who bring them up they're rubbish.
Yeah.
And only later does the recognition come back that this was the thing. And you have to be prepared to face that level of criticism from the community. And the only way I could do that was being reasonably senior in the community already.
Yeah.
And therefore I can withstand that hostility. Although what I've come to realise, and this is probably the last point, when you feel uncomfortable about what you're saying, when I first learnt tapping 25 years ago, I was so excited about tapping. And I tried to sell it to everyone. Like, come on, you've got to see this thing.
It's great.
It's amazing. And that meets resistance.
Oh, hello, yes.
When you just quietly get on with it,
Do it.
and do it, people are interested. And so I've stopped trying to convince people of things and just share what I think.
Yeah, great. I love that tactic. Because obviously I'm in the same boat. I'm just kind of quietly doing my thing, and now I've got universities from around the world getting in touch saying, can we come and research what you're doing? Because patients that are coming to us are talking about your work. And I'm saying, sure.
It's amazing, your work, by the way.
Thank you.
This is a very important piece of work.
Yeah.
And thank you for doing it.
You're so welcome, James. It's been an absolute pleasure.
Yes.
Thank you.
Thank you.
Thanks so much for listening to the Rest, Repair, Recover podcast. If this episode brought you comfort, insight, or even a little spark of hope, I'd love it if you left a review. It really helps more people find this kind of much-needed support. And if you know someone that needs to hear this too, please share it with them. I'm sending love, as always. Look after yourselves.